couple topics of interest and to begin to frame a conversation that I hope will carry on after the meetings over the next 2 days. So to start, I just want to remind everyone that laterality really starts during early embryonic development before the organs are formed, and it occurs initially at an early embryonic structure, the left-right organizer, and cilia are very important for this process, in particular embryonic nodal cilia. And this is the reason why we see this association between primary ciliary dyskinesia and heterotaxy, and as well between some types of isolated heart defects and cilia potentially. So of course, heterotaxy is fundamentally a disorder of left-right asymmetry. And so we see abnormal arrangement of thoracic or abdominal organs relative to the left-right axis. And then also typically cardiovascular malformations that would be consistent with abnormal heart looping during development. And those are frequently coupled with multiple congenital anomalies. So in the picture here, you see situs solidus on one end of the spectrum and situs inversus on the other end of the spectrum. And then, of course, you can get multiple different arrangements of the visceral organs during this left-right patterning process. So there have been a lot of names used to describe different parts of left-right patterning and laterality. So situs inversus totalis, visceral situs inversus, thoracic situs inversus, and then heterotaxy, as I've mentioned, visceral heterotaxy, visceroatrial heterotaxia. So there are some questions then, are we talking about the same thing? If we say visceral heterotaxy and we say visceral situs inversus, there's left isomerism, left atrial isomerism. Are these used interchangeably or do they mean something different from each other? And this is where, while they have developed to try to help us be more precise, I think we need to be very clear about the anatomy when we're talking with other individuals to make sure that we're on the same page. Then you get into the asplenia, polysplenia syndrome, Eibmark syndrome, other terminology that you see here. Also, the embryologic terms, left-right patterning, embryology C-loop, S-loop of the heart, or just more generic looping. And that's before you even get into beginning to talk about segmental anatomy and the different nomenclature that goes with that. And then finally, situs ambiguous viscerum. So this can all be very confusing. And I think there has been a tendency for subspecialists to sort of focus on their organ system and the nomenclature related to their organ system. And so it can be a bit like this picture where everyone is describing the same thing, but it's described a little bit differently depending on what your area of specialization is. However, I might suggest that in some ways it's even a little bit more extreme where we're all kind of dealing with our particular part of the elephant and not even really communicating to each other that often or that frequently. And so I think that this has some potential for not being the optimal patient care, and we can strive to do a little bit better than this. And so just as an example of some of the miscommunication or misperceptions that can occur, I'll give an example from myself. I had been working in the laboratory on the developmental biology of left-right patterning for some time, several years, and had been seeing heterotaxy patients in clinic for several years at the time this paper came out. And so this is a really nice study on the epidemiology of laterality defects. And it was done by Angela Lin, who's really very well respected in the field for her deep phenotyping abilities and for her knowledge, both as a geneticist and as a cardiologist. And the National Birth Defect Prevention Study is a national epidemiology and environmental risk factor study that occurs in 10 parts of the United States and had been collecting data for 30 years. And so it was a really good opportunity to describe laterality cases. And so when this paper was published, I really avidly dug into it. And this table really sort of stopped me in my tracks because in all of my kind of work, I had always described cytosine versus totalis as the complete mirror image. So to me, that meant that the patient did not have any structural cardiac abnormalities, had dextrocardia, but structurally the heart was normal. And if the heart was abnormal, then that almost by definition was heterotaxy. And so I quickly noted here in the birth defect prevention study that almost 40% of the patients with cytosine versus totalis had some type of congenital heart defect. And so this is actually the table from that study where they have defined heterotaxy. And we now use this definition, although a little bit more loosely in a number of the studies that we're doing. This is a very nice definition, but it is fairly stringent in that heterotaxy requires at least 3 features from groups 1 to 8 here. And group 1 is a fairly extensive list of characteristic congenital heart defects. And then you have the morphology of the atrial appendages, as well as the venous anomalies treated separately. And then beyond that, you have the other organ systems that we commonly see with excitedness differences in heterotaxy. So is it heterotaxy? Tom and Adam Shapiro really drove this paper that came out a couple of years ago now for a comprehensive approach to management of children with heterotaxy, which I think is very much needed. The question, though, is are all of the patients going to get the management they need if we don't have a very solid definition of what to include in heterotaxy? So I think we would all agree that an unbalanced AV canal, interrupted IVC, epiarterial bronchi, asplenia, right-sided stomach, midline liver would be someone considered to have heterotaxy. But what about someone with complex congenital heart defects, including LTGA and DOR, but normal situs of liver, spleen, and stomach and a malrotation? Are we going to call that heterotaxy? That only has 2 organ systems involved. Or what about an even more simple heart defect, ASD, and a left-sided liver and the other anatomy not yet defined? Finally, take the case where there's no congenital heart defect, maybe a 4-year-old who had a volvulus and went to the OR, found to have malrotation, and also multiple splenials were noted at that time. So polysplenia got put into the electronic medical record. Is someone going to call this patient heterotaxy, and do they need more of a diagnostic workup? So I think these are important questions for us to deal with, and they're important from a research standpoint because we would like to have more precise coding. We also would like to be able to make sure our inclusion criteria are standardized and that we have good registries, the good ability to do natural history studies and outcomes. But more importantly, from a patient care standpoint, I think if we are not able to do this well, then there's a possibility for missed or delayed diagnoses. And certainly in talking with patients, I've heard this multiple times of them, not knowing that they had an immune deficiency until they were in their 20s, for example. And then just in terms of the patient family experience, we risk these diagnostic surprises. Some isolation where families are told that they have never seen that anatomy before, where in reality they could be told, oh yes, this is part of heterotaxy spectrum. And it means that we're requiring the families to really develop the medical sophistication and advocacy across specialties rather than us being proactive in doing that. So hopefully this will give us some things to think about as we go forward over the next 2 days. And I very much look forward to all the discussions.